Good evening, everyone. Welcome to tonight's clinical webcast, Enhancing Patient Satisfaction and Practice Profitability with the Oculus Easyfield VR. Unfortunately, our speaker, Dr. Bill Tullo, is unable to join us live this evening. However, he has pre-recorded tonight's session to ensure we still benefit from his valuable insights. While we won't be able to conduct a live Q&A tonight, feel free to submit your questions into the text box and we will respond via email. We have also selected several previously submitted questions for discussion at the end of the recording. One final housekeeping note before we begin. The Easyfield C is available in the United States and internationally. The Easyfield VR is approved for sale only in the United States. Our speaker tonight is Dr. Bill Tullo. Dr. Tullo is Chief Medical Officer of Oculus Inc. Previously, he was VP of Clinical Services for TLC Laser Eye Centers for more than 20 years. He has maintained a private practice in his hometown of Princeton, New Jersey since 1988. Dr. Tullo earned his Doctor of Optometry degree from State University of New York College of Optometry, where he was also an assistant clinical professor from 1988 to 1997. Dr. Tullo has been Fellow of the American Academy of Optometry since 1990 and a member of the American Optometric Association since 1984. In 2011, he was recognized by the American Academy of Optometry as a diplomate in cornea contact lens and refractive technologies, the Academy's highest honor. So without further ado, let's dive into the presentation and hear from Dr. Tullo.
Good evening, everybody. My name is Dr. Bill Tullo, Chief Medical Officer at Oculus Inc., and welcome to Enhancing Patient Satisfaction and Practice Profitability with the Oculus Easyfield VR. Thanks for joining tonight. I wanted to share my experience of incorporating a VR headset into my private practice. Been in private practice for 36 years in Princeton, New Jersey, and I've always relied on bulb perimetry to do my perimetry. And I wanted to talk a little bit about my experiences with incorporating a VR headset into my private practice. As you all know, the importance of visual field testing. Estimated 80 million people worldwide have glaucoma and 11 million will be blind in both eyes. It's a frightening statistic. In the United States, 2.7 million Americans have glaucoma and only half of them are aware of it. That means there's well over 1.3 million people walking around in the United States with glaucoma and being totally unaware of it. And it's for a lot of reasons. Some of it is access to eye care. Some of it is the efficacy of screening patients with finger counting visual fields and the fact that glomatometry is only one indicator of glaucoma. So we have a problem and we need to work on a solution for these patients. Now, as you know, there are two types of perimetry. Standard automated perimetry, or SAP, is a traditional white-on-white perimetry, typically using a bowl that is white with a white light stimulus to determine sensitivity of the different areas of the retina. And it's the most common form of perimetry used in the world. We also know that there is frequency doubling perimetry, which may be more sensitive, depending on the studies you read, for screening for early detection of visual fields. We know in general with glaucoma, visual field loss is not necessarily an early finding. We can have significant loss of ganglion cells well before visual field is picked up. But in some studies, frequency doubling perimetry shows a greater sensitivity for early detection. But we don't commonly use it for threshold testing, and we're going to talk a little bit about that as slides go on. So let's talk about how the headset works, and patient instructions for doing a visual field in the headset is almost the same as it would be in a bulb perimeter. There's going to be a red fixation cross, and we're going to ask the patient to look at that cross until the test is complete. Lights will flash in different locations during the tests. If it's a threshold test, some will be brighter and some will be dimmer. If it's a screening test, they're all going to be the same level of illumination. And we tell patients you're not expected to see every light, and if you think you see a light, pull the trigger on the controller. If you want to pause the test, just ask the tester, and the tester can pause the test for you. And you may blink during the examination. It's important that they don't stare until their eyes dry out. So when we tell them the best time to blink is right after you see a light stimulus and you hit the patient response button, and then ask the patient if they have any questions. So it's pretty straightforward instructions because the rest of the test will be automated by the headset. One of my concerns was this going to be really difficult to maintain sanitation of the device as we put it on and off patients? But this shows how simple and quick. It only takes about 5 or 6 seconds to wipe the headset down and sanitize all the patient contact points. So that concern that I had was easily alleviated. My technicians say, no, this is not a big deal, pretty easy to do. Placing it on and off the patient's head also is also very easy, even with different hairstyles and patients that have their hair in ponytails or buns. It's actually not a hard thing to do, and it fits virtually every patient's face and head. So I was concerned that there would be a lot of patients where we just couldn't do this because of the fit, but that's not the case. It seems to work with everyone. And the device has an active eye tracking, which is really beneficial because it will help for performing visual fields at a more accurate pace. We can always switch to blind spot monitoring if we want to, but the active eye tracking has worked out in almost all the cases that we've used it in. Selecting examinations is really easy for our technicians to understand. There's a menu on the left-hand side, and doctors will instruct them what tests we're going to do, and it's really a pretty simple, straightforward process. As far as what tests are available, for a regular SAP visual field screening, we have fast screening 24-2, the super testing, ptosis testing, Esterman testing, and then we have the 3 visual field threshold tests, the SAP 10-2, the 24-2, and the traditional 30-2. And we have additional other pre-screening tests, including color vision, contrast sensitivity, and stereo acuity. Additionally, we recently added frequency doubling perimetry, which is really a great addition to the headset. We have 2 screening tests, the 20-1 screening test, which is a target that 99% of the population can see. It takes about 40 seconds to perform, and similarly, the 20-5, which is seen in 95% of the population, also takes about 40 seconds. And interestingly, additionally, we have a frequency doubling threshold testing, both in the 24-2 and the 30-2, and they take 6 to 8 minutes to do also. So lots of choices and options depending on what you're accustomed to and what you've done historically in your patients. And if you're accustomed to using frequency doubling, especially for screening, you can do that. And you can also use standard perimetry also on these patients. Here's what the printouts look like, and this is the screening FD perimetry printouts. It should look very similar to what you've used in the past, and all the information that you need is included on the printouts. And this is DICOM compatible, so you can feed this into your EMRs, or you can print it out and scan it. Here is the threshold of frequency doubling perimetry printout. Again, looks a lot like your standard printouts that we're used to with threshold testing. On the left-hand side, you'll actually see a visualization of what the patient sees. The headset will talk to the patient.
To begin testing, pull the trigger. Focus on the target and pull the trigger when you see a pattern appear.
In a moment, you'll see the frequency doubling pattern start to appear.
Great job. When you see a pattern, pull the trigger.
So it's very helpful that the headset walks the patient through the testing, and it actually frees up the technician to actually multitask and start working on other tasks and start working up other patients or getting things ready for the next patient. We'll talk a little bit about that at the end of the presentation, about how the efficiencies work and how the technicians love the fact that they don't have to sit during the whole visual field and monitor the eye tracking part and making sure everything is centered and making sure they have to pay attention. They can actually move on to another task while the patient and the device works the examination. So it's really self-sufficient, and it looks very much like perimetry testing that you've done in the past. The printouts are also, as I said, DICOM compatible and PDF, so you can print them out, you can scan them, you can send them to EMR systems. So it's very similar to most other visual field devices out there in that sense. So it's a very familiar task. Here are some of the SAP visual field printouts. Again, on the left, the screening tests. Again, and these tests are really very quickly performed, and there's lots of different patterns you can use. On the right-hand side, we see a threshold test again, and this threshold test in particular was only 2 minutes and 49 seconds. Here are some of the basic patterns that we can use. I tend to use the fast screening, the one on the left, to 20-point exam, and it's only about 40 seconds per eye. Pretty quick and pretty efficient, and the technicians love to do that. But you also have a 24-2 screening, which is a little bit longer, about a minute per eye, and also a super test, which is about a minute and a half per eye. So you have several different options on your SAP visual field screenings, whichever fits your practice modality the best. But again, I would tell you that this is way more effective, more sensitive and specific than finger counting visual fields. There's also ptosis fields where we do it taped and untaped, and you can see again here in the green boxes are the untaped and the blue is taped. So you can see the differences between taped and untaped. At halfway done, the test will pause, so you can take the headset off, tape the patient's lids, put the headset back on, and resume the test. We also have the Esterman test, especially in states where Esterman is required for the motor vehicle testing. Again, it's about a 3-minute test. It can be done OU, and we get a 160-degree horizontal field and a 100-degree vertical field. So, again, very useful for the full field testing that may be required. SAP threshold exams, again, the 10-2 is about a 3-minute test, similar to the 24-2. It's a little bit shorter, and the 30-2, which is about 3.5 minutes. So, again, the testing is quick and efficient, which patients will comment on, and I'll share with you. And if you've done 3 tests, you can do a progression analysis here. And you can see the 5% confidence intervals on the green dashed line. So you see in this example, this patient has performed 4 examinations, and the blue line is the plot of the decibel loss over time. And again, obviously, the more negative the slope, the greater the progression for the particular patient. So very helpful in determining whether or not your treatments are effective. The headset uses something called the Super Zest strategy, a little bit different from some of the strategies that you might be familiar with, such as the CETA testing or the Spark testing. But the Super Zest testing has been validated, and here's one of the studies from the University of Iowa showing the validation of the Super Zest testing. It's a little bit different because in the headset, what we do is we make the stimulus size, instead of getting brighter as we go peripherally, we make it get larger. So we have an equivalent stimulus. It's just a change in stimulus size instead of stimulus intensity. It results in a fast test duration, and patients prefer this testing with the headset, mostly because of the physical nature of it. Patients that have done bowl testing and go on to using headsets will always comment, it's so much easier. I can have a normal head posture. I can change my posture during the testing, and I don't feel like I'm stuck inside of a bowl. The testing being a lot quicker, too, it also helps for patient satisfaction. The one difference, though, is the pattern standard deviation does differ from your traditional HVF visual fields in your severe end-stage cases, simply because the limitation on headsets currently is about 30 decibels in brightness. So if you have a really profound visual field loss, they may hit the limit of these visual field headsets. Contrast sensitivity testing.
To
Here
begin
you can see
testing,
the
pull the
patient has a
trigger.
pointer, and they just match the letter E to the direction that it's going in. It's a pretty simple test for them to do. And in the end, it gives you a result in percentage of contrast lost. The stereo testing works very similarly for the patient. They have a pointer and they point to the circle that seems to be
begin
coming out
testing,
towards them.
pull the trigger.
And as it goes down in arc seconds, once the patient fails, they'll give it a result in arc seconds, similar to what we do in the manual testing. And color vision testing, the plates are based on the Good Light Color Check Complete Vision Screener. The nice thing about this color vision check, not only does it check for protan and deutan defects, but it also has some plates for the tritan blue defects also. So it's a nice comprehensive test, and it works just like the other tests where the patient is asked to match the number. So it shows them a plate, and they see the number 62, and they have to point to the number 62. And that goes on for all 15 plates. So what is the return on investment? Why did I decide that once I had this in my private practice, I really couldn't do without it? So the practice benefits and really the enormous difference was the reduced technician time in working patients up. What it effectively did in my practice was it increased the efficiency by 33%. That technicians were able to work up, instead of 4 people per hour, 6 patients per hour. And if you look at the monthly cost savings, and I do pay my technicians, well, $35 an hour, but look, I'm saving about $2,000 an hour just in technician salary, not to mention the fact that I can get more patients through the practice. Having 2 doctors work at the same time, it's very effective to have 1 technician work up all the patients. I'm getting reliable results that are repeatable. The eye tracking is really best in class eye tracking. It works great, but we can always switch to the blind spot monitoring if we desire it. No internet connections required, so we can easily move this device to any room or any location in the practice that we need to, so it doesn't take up space in the pre-testing room and slow things down for other testing. It's available in English and Spanish for the audio support to the patient, and it does integrate with all Oculus devices in the patient management system. And again, you have the world-class support of our Oculus technical support. Patients, though, the benefits to them are the tests are independent of room illumination. If you don't have to worry about wearing a patch, it's lightweight and comfortable. Faster testing results in reduced patient fatigue, and again, easy to sanitize the device between exams, so the technicians actually love this device. As far as the business case for it is, the other thing that I realize is switching from doing finger counting examinations results in a lot more revenue to the practice. And this is just an example from my practice where we do about 150 comprehensive eye exams a week. And it's resulted in an annual profit of $150,000, and we capture about 80% of those comprehensive eye exams. And what that results in, if you look at additional threshold visual field testing and returning from medical office visits due to the difference between the sensitivity of this screening device and our previous methodology of using finger counting, also additional OCTs and photos, and also additional revenue that's not even accounted there in the additional testing we're doing for phototoxicity, ptosis testing, motor vehicle testing. So it really is a very profitable device for the practice, and I can't even imagine going backwards. So just a summary. This is an older slide. It says 9 out of 10 patients prefer the VR visual field testing, but I'll tell you that it's 99 out of 100 patients really prefer this to the ball testing. We still have our ball, and we still do use it for certain things, but this test could work. This device can work even without having a ball perimeter. Faster patient workflow and throughput, significant time and cost savings for the practice, and again, primarily through technician time. State-of-the-art equipment. Our patients always comment about how you guys always have the greatest, newest technologies, and this certainly feels like that to patients. I was very concerned that our older patients wouldn't be able to do this, but I'm pleasantly surprised that even our 80-year-old and older patients had no difficult time doing this visual field, at least no more difficult than they do with the ordinary bold visual fields. And this technology is upgradable. There's more testing coming. We're going to have HRR color vision, Fourier testing, pupillometry. A lot of things will be added to this over time. So it's really an exciting technology. And it's a technology, if I'll be honest, that when I was evaluating it at first, I said, this would be fun, but as soon as the evaluation's over, I'll be sending this back. But it became clear very quickly that not only was it profitable for my practice, my technicians loved it, my patients loved it, and there was just no way I was going to go back after the evaluation period was done. So I hope you have some good questions, and if you have any questions that we don't have time for tonight, I'm happy to answer them via email. Here is my email address, and thank you so much for attending tonight. And Michelle, I'll turn it over to you for questions.
So if you wanted to monitor patients on the Easyfield VR, how would you go about approaching that in your clinic? Or how have you been approaching that in your clinic?
So all new patients will get the Easyfield VR testing, and all comprehensive eye exams will get screened with the technology. But if I have patients with previous detected pathology that have already been measured on another device, I try to keep the patients on the device that they originally were tested on, simply because doing progression analysis and looking at the changes over time is a lot easier comparing apples to apples. And there are no two technologies that easily compare to each other. They may be equivalent, but they're not equal. And it could be a challenge to take any device and look at the results of that test and then compare it to another device's results. So I certainly, if I detect glaucoma in a new patient and I haven't done any threshold testing on them, I will start them on the Easyfield VR headset. But for previous patients who I've been following over the years, I'll try to keep them on the technology that I have. That's what I've chosen to do, but other practitioners will just simply switch over to the threshold testing with the Easyfield headset. And for them, that can work out well too.
Thank you for answering that question. Have you seen a benefit to the patients being able to wear their own prescriptions while using this device for visual field testing, color vision testing, anything along those lines?
It's a good question. Additionally to not needing an eye patch, allowing the patient to wear their habitual spectacle correction makes it a lot easier. For most patients, it's actually a wider field than the trial lens is, and it's more specific. So having them wear their habitual spectacle correction during these tests is very easy and simple for our technicians, and our patients enjoy that better than the traditional trial lens looking through.
Since this technology is relatively new on the market, have there been any challenges or benefits that you've seen when adopting this device into your clinic?
Well, historically in our clinic, one of the most difficult patients to diagnose is our patients that have normal tension glaucoma, since obviously their IOP is normal. And unless you do advanced testing with OCT or they have obvious optic nerve changes, these patients can go under the radar. And I have found that screening our patients with this device helps us pick up these patients that might go undiagnosed and have earlier detection of cases of normal tension glaucoma. So I've been really satisfied with the services we can provide to our patients in the earlier detection of disease.
Thank you, Dr. Tullo, for that great presentation. Do you have any final thoughts for the audience tonight?
Only that I encourage you all to look into this type of technologies. I was not a fan of the headset technologies before I actually used it in my practice, and I was really pleasantly surprised at the benefits it offered both my staff and my patients. So thank you all very much again for attending tonight.
Thank you to everyone for joining us this evening. Thank you so much, Dr. Tullo. If you missed part of the webinar or if there's anything you would like to go back and review, you will receive a link to the recording in the next week. If you have any further questions, please reach out to Oculus at the email shown here, sales@oculususa.com. This concludes the presentation on behalf of Oculus. Have a good night.